Welcome to the Primary Care Collaborative's March webinar, Prioritizing Prevention, Lessons from Million Hearts. I'm Ann Kemsky, an advisor to the PCC. We have expert speakers with us today who will describe different components of the Million Hearts Initiative and identify some key lessons learned as we continue efforts to lower the burden of hypertension and heart disease and set priorities to achieve better population health outcomes. Some housekeeping reminders as we wait for attendees to join us. All lines are muted for the hour. We'll take written questions in the Zoom app, and we've left the last 10 minutes of the webinar for answering Q&A, and you can submit your questions at any time. The webinar is being recorded, and slides will be posted, and the recording itself will be posted within 24 or 48 hours after the webinar. For those of you who are perhaps joining us for the first time and are unfamiliar with the Primary Care Collaborative, we are a national multi-stakeholder organization that convenes and unites stakeholders around primary care research, payment and delivery models, policies, and practices that strengthen comprehensive primary care for all our communities. We host monthly webinars like this one at no charge on a range of primary care topics, and all of our past webinars are available on our website at thepcc.org. I want to thank the American Heart Association and Melanie Phelps for co-hosting this event today with PCC, and also express our gratitude to the Commonwealth Fund and Arnold Ventures for support for this webinar. The Million Hearts Initiative was launched a little over 10 years ago with the goal of preventing 1 million heart attacks and strokes over 5 years by implementing proven, effective, and relatively inexpensive interventions. When launching Million Hearts, Dr. Tom Frieden, who led the Centers for Disease Control and Prevention at the time, and Dr. Don Berwick, who led the CMS, described the need for prevention strategies in the community and the clinic. And that's what we're going to talk about today, those strategies in both the community and the clinic. We are fortunate to have Dr. Frieden kicking off our discussion today. Before I introduce our expert speakers, however, I'd like to share a story from another expert, Valerie, a patient who has generously shared her story with us through our collaborator, Dr. Kevin Grumbach of UCSF.
Here's my story. I was so busy being a foster parent and a wife, and had a sick husband, and just taking care of everybody, just pouring into everybody and not pouring into myself. I wasn't checking my blood pressure. I wasn't doing any of that. I was just going. End up having a TIA. A couple of months later, I ended up having another stroke, and it was a big stroke. And I was paralyzed on the left side. And I'm still having that problem with my face right now on the left side. But I'm grateful because I got a primary care person. That was a godsend, and I am so glad that I was able to get her. And she found other things that was going on with me. I didn't know I had kidney problems. I didn't know I had bladder problems. She helped with all of that. Now, had I had her at the beginning, I probably wouldn't have had that stroke. I probably would have been able to take care of myself knowing that I had high blood pressure. I didn't know that. I didn't know I had high cholesterol. I didn't even know that I had diabetes. And she helped me with all of that and walked me through so much. And she was so caring.
Valerie's story helps ground us for today's discussion. I'd like to now introduce our speakers for today. In the interest of time, we're not going to read all of their very impressive bios, but we're going to hear from Dr. Frieden, who's currently the president and CEO of Resolve to Save Lives. We're going to hear from Dr. Eduardo Sanchez, Chief Medical Officer for Prevention at the American Heart Association, Laura Blue, a Principal Researcher at Mathematica, and Dr. Dr. Ikem Okeke, Founder and CEO of MedicaLinks. And I'm going to turn it over to Dr. Frieden to kick us off.
Great. Thank you all so very much. I'm delighted to be with you and to be reconnected with the important work of Million Hearts. I'm going to share with you some reflections based on the experience of Million Hearts and the importance of the issue of addressing the leading cause of illness, disability, and death, not just in the US, but all around the world. So I'll share slides and go through them quickly. I want to particularly emphasize not just the analysis, but where we go from here and what some of the essential ways forward are. I do want to be very blunt. We set an ambitious goal and we didn't succeed. And it's very important to not just try again, but to figure out why we didn't succeed so that the next time around we can do better. As I think you all know, cardiovascular disease is the #1 killer in the US and worldwide. Each year, nearly 2 million people in the US have heart attacks or strokes. Close to 1 million people die from cardiovascular disease in the US alone. That's about 1 out of every 4 deaths globally. It's more than 18 million deaths per year. We spend more than $400 billion a year in both direct medical costs and indirect costs. Now, here's what's at stake globally. If we keep on doing what we've always done, we'll get worse results than we've always gotten. Currently, we're at 10.7 million deaths per year related to hypertension alone. The red line indicates what will happen if it just continues on a straight line. And actually, that in some ways is optimistic because the world is aging and this is a number of cases. So this may actually increase. The green line indicates what could happen if we have effective control reaching globally 50% hypertension control, which means that in places like the US, we need to be at 60, 70, 80%, and we can be. Million Hearts looks at both community and clinical prevention, tobacco control, sodium reduction, trans fat elimination. In clinical work, focus on the ABCs, particularly blood pressure control, through health information technology and clinical innovations. Hypertension control can save more lives than any other healthcare intervention. This isn't a complicated concept. It's a simple question, but it's not asked often enough, not answered often enough, and not acted on often enough. High blood pressure kills more people than any other condition, and globally, more people than all infectious diseases combined. And we know that lower is better. Every 20 millimeter increase, starting at 115/75, doubles the risk of cardiovascular death between ages of 35 and 69. And we know from the SPRINT trial that lower is better, down to at least 120/70. Now, work from Bangladesh shows that even in a low-income environment, systematic approaches can triple control rates. This is a program which was able to vastly increase the number of patients treated from 5,000 to 300,000, while tripling the control rate from 20% to 60%. First, the good news. Smoking cessation met the 2022 target with a relative 22% reduction to an all-time low, but more can be done. The FDA can regulate the amount of nicotine in tobacco products down to non-addictive levels. This substantially reduces cardiovascular risk. FDA has been working on nicotine regulation. It's authorized to do it, but it hasn't done it. There are competing priorities, industry opposition, and court challenges, but we need to move forward. Good news on artificial trans fat elimination. In 2015, the US removed it. This was fully implemented in 2021. This is in line with the global best practices called the Replace Technical Package. In the US alone, this will prevent 250,000 heart attacks and 50,000 deaths per year. Globally, since our Replace package was launched with the World Health Organization, we've seen a steady increase in the number of countries that pass trans fat elimination regulations and laws, and currently just under half of the people in the world in countries that accounted for nearly 2/3 of the consumption of trans fat are protected or in the process of being protected by trans fat regulation. This is a real win. But we've not yet bridged the implementation gap, the gap between what we know and what we do, and we need to be blunt about why that's happening. We've lost momentum achieving the U.S. hypertension goals. This is a very painful slide for me. We launched the Million Hearts Initiative, and we said, we're going to focus on increasing blood pressure control rates, and they went down. Not only did we not go up, we didn't prevent them from going down. Million Hearts did not succeed. That's the polite way of saying it failed. And we have to ask, why did that happen? What was the cause of that? And I think really, if you look at what our goal was between 2012 and 2016, it was to prevent 1 million heart attacks and strokes. That wasn't some vague estimate. That was an actual calculation. And the best estimate is that about 135,000 cardiovascular events were prevented. But that's cold comfort to the other 865,000 people who had heart attacks or strokes or their families after their death. And as just shown, blood pressure control actually decreased despite increased insurance coverage, and the decades-long decline in the CVD death rate stalled and began to increase. In fact, this is the strongest driver of the tragic decrease in life expectancy in the US, though other issues, including the horrific overdose epidemic, get coverage. People haven't really absorbed the fact that the driving cause of our flailing and failing life expectancy increase is the failure to prevent heart attack and stroke. The bottom line is the bottom line here. Exhortation fails. Exhortation fails. Health system financing needs to make prevention pay and impose meaningful financial penalties for the failure of prevention. If a healthcare system fails to control blood pressure, and therefore a patient has a stroke or a heart attack or needs dialysis for the rest of their life, that should come out of the bottom line of the healthcare system. Let me assure you, if CMS does that, we will get to 70 or 80% blood pressure control, just as Kaiser Permanente does, because it has that inbuilt financial incentive. And if we don't, we'll just continue to fail with exhortation. Healthcare system financing needs to make prevention pay and have meaningful financial penalties for failure of prevention. You're going to get all sorts of objections to this. Oh, it's not my fault. Patients didn't take their medicine. They were someone else's patient before. They didn't come in for care. You know something? Doesn't matter. Bottom line is the bottom line. Exhortation fails, money talks. Now, in terms of sodium, FDA guidance on voluntary sodium reduction targets was issued in 2021. These don't have mandatory reductions, but mandatory reductions with mandatory maximums are more effective and possible. And we need new interim targets, which the first 2.5-year period ends next month. Front of pack warnings are a best case approach. High in, a very simple approach, telling people, hey, there's something bad in this stuff. You maybe want to order something else, buy something else. And when you have that front of pack warning, people do make healthier choices, and industry quickly adjusts so they don't have to put that scarlet or black box on their product. The regulatory process is slow and obstructed by current judicial interests and current judicial context. There's also a lot of potential in promoting potassium-enriched low-sodium salt, which can reduce cardiovascular events and cardiovascular death by 10 to 15%, just changing the brand of salt you consume. We can do that by promotion, by subsidy, and by other measures. So thank you all very much. It's wonderful to be here with you, and I look forward to seeing how we move forward to make sure that prevention pays and failure of prevention does the opposite. Thanks very much.
Thank you, Dr. Frieden. And we remain grateful to you for your commitment on this issue, which, as you said, and we couldn't agree more at the Primary Care Collaborative, we need to make prevention pay in this country. And I also like the phrase, I never get tired of it. We need to make the right thing easier for people to do, both in the community and in the clinic. And with that, I want to introduce Dr. Eduardo Sanchez, who's the Chief Medical Officer for Prevention at the American Heart Association. And the American Heart Association was on board with Million Hearts from day one and has never taken its eye off the ball since. And it has a special focus on the inequities and the different outcomes we see in different communities across the country. So with that, I want to turn it over to Dr. Sanchez.
And thank you so very much for having me, Dr. Frieden. Thank you for your leadership and your voice. I'm going to try to run through a very high-level description of where the American Heart Association is, and we are so pleased to be co-hosting this webinar today. Dr. Frieden said a key word, and that was systematic approaches. So I want to talk about systems, standards, and protocols, and how when those are applied with adequate resourcing, lots of great things can happen, and how starting with blood pressure control makes sense. So prioritizing prevention of cardiovascular disease to further prevent heart attacks and strokes aligns with our mission and vision. And I would say we have sequentially prioritized blood pressure control as a starting point, and Valerie's testimonial to me says, you got to start somewhere, and blood pressure control is a place to start and then address other things. So I serve as the principal investigator for the National Hypertension Control Initiative, and you already heard we are partners with Million Hearts. Our mission statement is to be a relentless force for a world of longer, healthier lives in the hopes of advancing health and hope for everyone, everywhere. Next slide. We have, as an organization, characterized 8 essential elements to achieve ideal cardiovascular health. How can you best achieve cardiovascular health? The life's essential 8 are not smoking, getting plenty of sleep, healthy eating, physical activity, healthy weight, blood pressure, blood glucose, blood cholesterol. If those things are not where they ought to be, and medications can make a difference, that can get you to that ideal cardiovascular health. Next slide. Having said that, though, of those 8, 7 have been looked at as how they might rank as risk factors for cardiovascular disease, and Yusuf et al. Have applied population attributable fractions for these, and you could see hypertension, high blood pressure is at the top of the list. Dr. Frieden made the case for why that might be a good place to start. Next slide. In addition, the U.S. Surgeon General did a call to action to control hypertension. The World Health Organization last year put out a global report on hypertension. It is top of mind. It is maybe exhortation to get us to be systematic about what we're doing. Next slide. Mentioned earlier that I serve as the principal investigator for the National Hypertension Control Initiative. That was a cooperative agreement that we had the privilege of undertaking with funding from the Office of Minority Health and HRSA, the Health Resources Services Administration. Our charge was to try to help improve blood pressure control in 350 community health centers that were not performing as well as their peers in blood pressure control using training and technical assistance. Next slide, please. Before I talk any more about the things that AHA is doing, I figure someone is going to talk a little bit more with detail about the disparities in blood pressure control by race, ethnicity in this country. Critically important. I figure a lot of you know this. I figure it's going to get talked about. But equally important is that coexisting with those disparities and perhaps exacerbating them are the blood pressure control disparities that are related to socioeconomic factors. And just very quickly, high school education correlates with better blood pressure control. Household income correlates with better blood pressure control. Having insurance correlates with blood pressure control, and what type you have might improve blood pressure control a bit. But maybe the most important is that not having healthcare in the past 12 months is a predictor of low blood pressure control among persons already diagnosed with hypertension. Next slide, please. The National Hypertension Control Initiative used a systematic approach to implement and make use of the MAP framework. The MAP framework is M for measure accurately, the right technique with the right equipment, validated blood pressure devices, act rapidly when the blood pressure is above goal, very quickly intensify treatment until you get to blood pressure control, following people in 2 to 4 week intervals. And P, partnering with patients is making the patients the center of that work. Make Valerie be one of the drivers of care, including self-measured blood pressure monitoring. Next slide, please. The National Hypertension Control Initiative is still waiting to see final results over the 3 years, but from 2020, when blood pressure control levels were quite low across the country because of COVID, we've seen or we've helped to contribute, we think, to a 12% relative increase in blood pressure control in the 346 health centers that are part of NHCI. Next slide, please. The work that we do at the American Heart Association prior to NHCI and still ongoing and is a bigger program is Target BP. It is a joint venture, a joint initiative with the American Medical Association. We leverage, and let me be clear, the MAP framework was developed by the American Medical Association. We use the MAP framework in Target BP. Next slide. What we've been able to accomplish in Target BP is to engage 1,800 healthcare organizations from federally qualified health centers to large health systems that are serving 8.5 million persons with hypertension. That plus the unduplicated number of persons that we are serving or were serving with NHCI comes to about 10 million persons with hypertension in the United States. That's over 10% of all persons in the United States with hypertension that we've been able to help provide the healthcare organizations, the systems, standards, and protocols with sometimes some additional funding to get to the business of blood pressure control. Next slide. I'm going to just allude to this and suggest that with a little bit more time, you have a look at this new scientific statement from the American Heart Association, American Medical Association, implementation strategies to improve blood pressure control in the United States. And I just want to have you see that to the far left, use of financial levers is one of the components that's identified as among the strategies to improve blood pressure control. And I'm going to close with my favorite quote these days, and that is that I'm not an optimist. I'm a very serious possibilist, and I believe that already Dr. Frieden and I have suggested we have the tools, we have the know-how, we just got to get the work done by using a systems approach, using the resources, getting more resources, and getting it done. So thank you very much for inviting me. I look forward to the rest of the presentations and panel discussion.
Thank you, Dr. Sanchez. And thank the AHA for continuing your very dedicated focus on this issue. And we hope that we can help amplify some of this work today. Now we're going to take it a little further into the clinic. And many folks don't know that there was actually a payment and delivery model associated with the Million Hearts Initiative. And it went on for a couple years, and Laura Blue from Mathematica is here to share a little bit about how that how that model was designed, and her and her team's evaluation of that model. So I'm going to turn it over to you, Laura.
Great, thanks. Give me one sec here. Okay, well, I'm honored to be here today. And as Anne said, I'll share some findings from the Million Hearts Cardiovascular Disease Risk Reduction Model, which was one component of the broader Million Hearts initiative we're talking about today. I should note that these findings reflect work from a large research team funded by the Centers for Medicare and Medicaid Services, or CMS, and my opinions today do not necessarily reflect theirs. Okay, so as I said, the Million Hearts Cardiovascular Disease Risk Reduction Model was one component of the bigger Million Hearts initiative. And the model was a 5-year randomized trial from 2017 to 2021 run by the Innovation Center at CMS. And I'm here talking to you today because the trial results released last fall show that the model met its goal to reduce incidence of first-time heart attacks and strokes among Medicare beneficiaries without detectable effects on Medicare spending. So what was this model? Well, at a high level, it had two main components. The first was participant commitments. So participating healthcare provider organizations signed formal participation agreements with CMS, agreeing to provide care concordant with clinical guidelines for the primary prevention of cardiovascular disease. And specifically, that meant calculating the 10-year predicted probability of a heart attack or stroke, often called a CVD risk score, for all of their eligible Medicare beneficiaries. These were beneficiaries aged 40 to 79 without a previous heart attack or stroke. And initial risk scores were calculated using the standard 10-year risk calculator based on the pooled cohort equations. And then for beneficiaries found to have high risk, meaning a risk score of at least 30%, the participants agreed to discuss CVD risk and jointly develop a care plan to reduce CVD risk. Participants further agreed to meet with those patients with high risk to formally reassess risk annually using a novel longitudinal CVD risk calculator developed for the model, and to encourage these and to contact these patients at least twice more per year to encourage and monitor risk reduction. So most of this, I'll note, is pretty standard care in a lot of ways, recommended in clinical guidelines, but the model participants committed to making CVD prevention a priority, and to Dr. Sanchez's point, to following the standards of care just more systematically. The second main component of the model was CMS payments, tools, and non-financial supports to encourage and support the participants' focus on CVD prevention. So CMS paid participants to calculate CVD risk and to reduce CVD risk. CMS offered a one-time payment for each eligible Medicare beneficiary who received a CVD risk assessment. Further, in 2017, they paid monthly cardiovascular care management fees for beneficiaries with high risk. And then one thing that was really novel about the model was paying for measured risk reduction. So participating organizations could earn money for improvements in CVD risk scores. The CMS non-financial supports included a data registry, data feedback tools, and cross-participant learning events, generally webinars, to share best practices. Okay, so 345 healthcare provider organizations participated by enrolling at least one Medicare beneficiary in 2017 or 2018, split roughly 50-50 between the intervention and control groups. And they were a diverse group comprising primary care practices, specialty and multi-specialty practices, community health centers, and hospital outpatient departments located all across the US, and with many participating concurrently in other CMS initiatives, including in particular the Medicare Shared Savings Program and Comprehensive Primary Care Plus, or CPC Plus. Together, the participating organizations enrolled hundreds of thousands of eligible beneficiaries aged 40 to 79 without a previous heart attack or stroke. And our study focused on the population with high or medium risk. Now, there was substantial attrition from the model. Only 46 of the 173 intervention group organizations were still actively participating, submitting the data needed to receive model payments by the end of the model. And in interviews, participants told us that data reporting burden and the model's modest payments were their main reasons for stopping participation. What's more, participants said it was really hard to maintain a focus on the model during the COVID-19 pandemic with so many competing priorities and staffing constraints. Now, fortunately, most of our study outcomes come from Medicare administrative data, so we could estimate effects for all fee-for-service Medicare beneficiaries, even if their organization dropped out of the model. As intended, the model substantially increased the use of CVD risk assessment. We did a survey of healthcare providers in the intervention and control groups, and before the model launch in 2016, about a quarter or a third of providers already said they calculated CVD risk scores for at least half of their Medicare beneficiaries. But by 2018, a year and a half into the model, the rate was much higher in the intervention group, shown in the blue bar, than in the control group, shown in green. And the intervention group's more systematic use of CVD risk assessment seems to have kicked off a causal chain as intended, where then beneficiaries in the intervention group were more likely than those in the control group to start or intensify statin or antihypertensive medications. Their risk factors, as best we could measure them, improved more than in the control group. And ultimately, the intervention group had a lower incidence of heart attacks and strokes over 5 years than the control group, with no detectable effect on Medicare spending. So let's talk about the magnitude of these effects for a second. We observed that in the control group, shown here in green, 8.1% of the high and medium risk beneficiaries had a heart attack or stroke within 5 years, compared with 7.8% in the intervention group. This outcome was measured in Medicare claims and reflects any heart attack or stroke that resulted in a hospital stay or a trip to the emergency room. When we look at those same events plus anyone who died of coronary heart disease or cerebrovascular disease, again, the rate is a little lower in the intervention group than the control group. Now, these differences are not huge. They work out to a relative difference of about 3% or 4%. Still, I would argue that these differences are meaningful at the population level because these small differences represent about one averted heart attack or stroke per 400 beneficiaries with high and medium risk enrolled, or roughly one averted CVD event or CVD death for 250 beneficiaries enrolled. So with hundreds of thousands of people enrolled, we're talking about several hundred events prevented. To sum up, we found participants' commitment to CVD risk assessment and follow-up care, coupled with CMS payments and supports, reduced first-time heart attacks and strokes over 5 years. The magnitude of these effects was pretty small at an individual level, but meaningful over a large population. However, the model faced some challenges with participation. In particular, many participants said the model required too much effort to submit data, given the funding, and many reported challenges prioritizing the model during the pandemic. In my view, this model was distinctive in a few ways. So first, the novel risk reduction payments focused on patients' overall CVD risk rather than individual risk factors, and they rewarded providers for patients' improvements in that risk rather than getting to a specific target. So for example, a typical quality measure in MIPS might reward you for the proportion of patients with hypertension who get their systolic blood pressure down below 130. And it's been pointed out to me that the incentive there, probably not intentionally, is to focus on the patient who's right around that target and relatively easy to get to the goal. Paying for risk reduction, in contrast, gave an incentive to focus on the patient who's way out of control to try to improve, even if they're not going to make it all the way to targets. Now, the model did, of course, focus on primary prevention for a single condition, and I'll close by noting that, to my eye at least, the current CMS models to advance primary care are really seeking to improve whole person care and address funding of primary care generally, not just for a single condition. Back to you, Anne.
Thank you, Laura. And thank you for your for those who don't know, this is a very rigorous evaluation. It's I think one of the few, if not the only, payment model that really had a control group. And so that I think that makes the numbers that you found, while modest, it still reminds us that we save lives in primary care, and we can save lives, and we can save more lives. And the focus, the other thing about this model that's really unique in my mind is that it measured real outcomes, these cardiovascular events and death. And so it helps also remind us the stakes of lowering hypertension. So with that, I want to introduce Dr. Inkem Okeke. And Dr. Okeke comes to us with deep experience in practice transformation and delivery systems, working from many different vantage points. But really, I think of her as really on the front lines and trying to support all of the motivated clinicians who want to do the right thing for their patients every day and face many different kinds of barriers in doing that. She's an expert in different kinds of quality improvement, including the Kaizen method. And so she comes to us with a very good perspective here. And I really want to ask her to reflect on what she's heard and her experience in working with practices in very different situations, different communities, with this eye of looking forward, as Dr. Frieden said, what can we do better? What can we do differently? So over to you, Dr. Okeke.
And Dr. Okeke, it looks like you're muted.
Can you hear me now?
We can, thank you.
Yes. And can you see my screen?
We can, thank you.
Awesome. So thank you for having me. I'm Dr. Nkem Okeke, and primarily what I do these days is focusing on how I can support my practicing colleagues to really implement advanced primary care, which has different meaning to different people. And when we talk about the Million Heart Initiative, we realize that therein lies different things that other panelists have talked about in terms of preventive care, and that should be paid for and incentivized better. So what I will do is just quickly touch on a few things that I've done over the years, particularly one publication that is dear and near to my heart. So this was a collaborative that we did between a payer-provider agreement between 7 FQACs in Maryland and a Medicaid health plan. And at this time, we're supposed to try and address cost containment. And in trying to do cost containment and understanding what that entailed, it meant that there were preventable and avoidable utilization of healthcare services that we could address. One being poorly controlled conditions that eventually led to complications, of which controlling high blood pressure we found was something important that we should embark on, as well as diabetes prevention. So we went into this agreement with the FQACs to sort of identify what exactly it is that we need to do to support and see how they can better care for patients at their centers. And as you can see from here, what we tried to do was meet them where they are. We came with a blank sheet of paper. And when I say we, I was negotiating all of this from the health plan perspective. So what we did was that we listened. We listened to the practices, we listened to the physicians, we listened to their support staff and what they were saying before we came up with this agreement. And what was beautiful about this was that through that, I was able to develop a readiness plan for those who want to practice what I say team-based care at the core of advanced primary care, knowing that it takes a lot to get things done. You hear former presenters share their thoughts. Dr. Friedman said, we were not successful with the initiative, and this is why. Dr. Sanchez also mentioned a few initiatives that are going on and not seeing the kind of successes that we want. But when we peel back the onions a little bit more, what I realized was that little things count. So while we're doing the readiness assessment across the different elements of primary care, advanced primary care, from access and continuity to care management and comprehensiveness and use of data, and so on and so forth, you could see that there was just wide array of things that we need to identify and address at the practice and the clinical site level to be able to advance things. And that's what we started doing. Well, fast forward, we were able to provide prospective payments after we identified what the key pain points of the FQACs were. We were able to also allocate resources and funding based on the attribution. So we made sure that we were being reasonable to support the FQACs to do the work they need to do. Another thing also we applied here, which is very much in alignment with the way the Million Hearts Initiative is implemented, is using a risk stratification approach to identify not only how we incentivized, but also how we measured outcomes. So all of this in a nutshell, and the publication is there for you to dig deeper into it. But bottom line is that we saw that it helped in terms of our approach, in terms of focusing on what matters, 35% reduction in emergency room visits, 11% reduction in hospitalization for the Medicaid beneficiaries supported. And in this 3-year investment of about $4.4 million, it yielded about $19.4 million in savings. And the way we look at this is also being able to identify what we were able to prevent because we intervened, what we're able to prevent because we invested in prevention. So I think that that was one key takeaway. Now, fast forward, there are other hats that I wear, including being the faculty lead for the implementation of CPC Plus with CMMI. And when we were going to implement the MDPCP program in Maryland, we wanted to think of lessons learned. So we looked at a number of programs, including the Million Hearts Initiative. And since in the Maryland Primary Care Program, for those of you who may not know about the program, it is a CMS funded initiative to advance primary care and make sure that we focus on meeting our patients where they are by being able to move a bit away, significantly away from fee-for-service type of care delivery to one that is more of value and more focused on prevention. So through this, we were able to identify practices that were more advanced to be able to support their patients. And the FQACs that we were supporting were able to write to CMS, and after a year, with showing and demonstrating the work that we had done with them prior to that and all the initiatives they were part of, that they were ready to embark on this journey with 500 plus more primary care practices within the state. So that has just been really very fulfilling to see just the needle move a little bit. Has it solved the problem in a broader sense? No, there's work to be done, but I do appreciate the fact that we identify that the socioeconomic factors are a huge determinant of where we go from here. And I think the only pushback that you have from the clinical team is, what are we responsible for and who else is responsible for what? But I think pointing the finger to different sides of the house does not help anybody. So it's best that we do the best that we can. But looking at this slide, one thing we try to also do with the centers is tell them most of the great ideas are already things you know, already things we're doing. The problem is, what is the consistency and how broadly are we applying it? So this slide you see here was us also driving that point home with the other practices who had never done any type of advanced primary care initiatives or participated in any of those before, to say, let's look at what you already do in the center and the practice right now with your patients. It's still similar outcomes we're tracking, still similar interventions we're implementing. So if you see that alignment, then you can see how you can plug in and get to do the work involved to support the patients. I think the last thing that I want to sort of recap with here is the leadership. Is also important that leadership understands that change doesn't come easy, and change, whether it's at a macro or micro level, does require consistency of purpose. So what we try to do when we work with the practices is to keep hammering home that point and really making sure that they have all the support that they need to do exactly what it is that we think should be done, and making sure they get the right incentives, make sure we advocate as we can. As a care transformation organization in the MDPCP program, I'm one of 25 other organizations. This is beyond what we can share in this webinar, the short time allotted, but we provide everything that the practice can absolutely need in terms of data analytics, having a community health worker support them if that's what's needed, a licensed nurse who can follow up in between consultations with the patients, also supporting with a nurse practitioner who can do annual wellness visits when the physician's time is tied, and so many other ways we've identified to move the dial and support our patients. And even though our practices are doing well within the program, it still matters that more of us keep doing the similar work to be able to expand the work we do. So super happy to hear what others may say in terms of the questions that will come from the audience as well. But this has been very, very insightful to see it come full circle at a macro to a micro level of how we can keep supporting to prevent cardiovascular disease and definitely reduce the disability and death rates caused by it.
Thank you, Dr. Okeke. And I think now's a good time to bring all of our panelists back, and we can take some of the questions that have come through. And I want to try to highlight a key things, especially what we heard from multiple of you, several of you, including, the importance of payment incentives and the importance of really leveraging a team in primary care. And there's been some interesting questions put in the Q&A around quality measures and how we've set up the incentives around quality measures. But why don't we start with one, Laura? I'll start with you. A question came in about whether we have any evidence that that practices that are currently in MSSP or other value-based arrangements are achieving higher blood pressure control or any other measure we might have around hypertension.
Oh, wow. I'm forced to admit, I don't know. I mean, I'm almost certain that the shared savings participants need to submit, like as one of their clinical quality measures for the program, their proportion of patients with hypertension that meet target. My understanding is that, yeah, you could check the benchmarks of like how they're performing against other participants in MIPS, for example. As a researcher, I don't know. I'm not sure I would feel comfortable calling that a causal effect. It's a great question. I wish I had a better answer for you, Anne.
Well, and it's probably not a fair question because I think that really the traditional Medicare with the, besides MIPS, traditional Medicare doesn't have a systematic kind of payment collection, quality measure collection system yet in place. So we have some measures in Medicare Advantage, we have some measures in MSSP, we have these other demos. I don't know how crosswalked they've been and how well we can even do a comparison. So it wasn't really a fair question. But
yeah, I know that they're trying to move towards more of like a universal measure set that they would draw from across programs, but especially when you start then comparing to a non-Medicare population, there may be other measures that are just relevant to like a pediatric population or a pregnant women population that are not so relevant for the Medicare population. I think that has made it hard to just come up with sort of like a universal standard set of quality measures that are relevant for all settings, all providers, all patients.
Great. And one other contrast that was noted in the Q&A is that in the Million Hearts demonstration, the clinicians were really incentivized to find their highest risk patients and to bring down their risk of the highest risk patients. But an unintended consequence of some of the quality measure things out there is that maybe the incentive is to kind of go for the lower hanging fruit. I don't know if Dr. Sanchez, you want to speak to that. Is there a different way that we can be measuring hypertension controls so that and providing incentives so that it is really the highest risk patients that become the focus of the practice?
I got there before anyone said it. I'd say that this is one of those where we want to think both the and as opposed to the or. And it just seems to me that having a universal approach around a blood pressure control threshold that we are trying to achieve for all patients to get under, then with special attention to those who are a bit more challenging and or at high risk is the way to go. I also would say to you that when we identify that high risk patient, blood pressure control is but one of the things that needs to get addressed. Whereas with other individuals that are at lower risk, getting the blood pressure control might prevent them from getting into that high risk category. So it's an and trying to get that figured out is not simple. I will say, and I'm just going to go ahead and go there. There was a question about the measure that is commonly used for performance measurement of 140/90. And probably many on this call know that HEDIS put out a call for public comment. And I'm willing to say that the American Heart Association said we would love to see 130/80 added. And we went on to say we'd love to see a transition to 130/80 only, because we feel like that confuses on the one hand, and it allows us to settle for, as Dr. Frieden said, blood pressures that maybe are living higher than they ought to be living, because every millimeter of mercury you can bring blood pressure down makes a difference in people's lives and gets us to the Million Hearts goals of less heart attacks and strokes.
Great, thank you. Another question. We started Million Hearts a good 10 years ago now, though different components of it started at different times. But I think the assumption was that health IT was only going to get better over time and that it was going to become easier. Health IT was going to really be an easier tool to use for population health, including tracking blood pressures, tracking other metrics of a panel of your attributed lives in your practice. So I noticed that, one of the findings, Laura, was the data reporting burden of the model. And this model is not alone in creating data reporting burdens. So what's going on with health IT? Why is it not facilitating population health like it could?
That's another really big question. I think that, part of what it was for the CMS model in particular is that to be able to submit the clinical data needed to assess CVD risk and assess CVD risk reduction for payments, it wasn't enough for people just to be submitting their billing data. They needed to submit claims, and CMS set up a data registry where the participants could submit their data. I think, people had envisioned that this would then be a pretty easy process, that, you could just kind of plug in your electronic health record and everything would be beautifully interoperable, but at least in 2017, that was definitely not the case. So there were a few different data upload options available, but we found that about half the participants were just entering the data manually. Somebody was copying it from their EHR and typing it into the CMS data registry, and that, unsurprisingly, people found burdensome. And the payments, as you saw, they were not large payments. So a lot of participants felt that it was not worth their staff time to participate. And maybe like on a slightly more optimistic note to end there, a lot of participants did say that even after they stopped kind of formally, even after they stopped submitting the data that they would need to actually get the model money, they maintained that focus on CVD prevention because their clinicians had really bought in. They thought it was something really valuable that they could do for their patients and improve lives. So in some cases, we think that, the model really did actually move participants to change their care, even if they never fully realized the promise of the money on the table, given the challenges with EHR interoperability and interoperability with the data registry.
And Dr. Sanchez or Dr. Okeke, do you want to make a comment on the state of health IT for population health?
I'll defer to
And I
Dr.
can chime in
Okeke.
here. Yes, you were saying, sorry?
I was deferring to you.
Okay, awesome. I also support Dr. Sanchez from a distance. I serve on the American Heart Association Committee for Outpatient Quality Improvement. And out of that group, one of the key things we've talked about is data, having adequate data that informs us at a granular level. What are the disparities that we see in how we deliver care to really get to the bottom of that patient-centered care? As you know, most of the EMRs do not capture data at a granular level when it comes to identifying some demographics that we need. And what can we do to move the dial to advocate for that to happen is part of what some leaders in our committee are spearheading. And these are things that I think that matter. From my own personal experience, we have been forced in our organization to come up with our own health IT solution, because working with existing EMRs or EHRs as we walk across different practices has not been easy. Not easy for them, not easy for us. There's not this one-on-one understanding between them and the vendors in terms of what they need to have decision-ready data to inform what they're doing. So there's a lot of patchwork, walk-around spreadsheets being used. It's not something that it's easy to own up to and be honest about. So what we've tried to do is see how we can make it work, but it does take a lot of workarounds. And I think the more that we can keep trying our best to have those who are already players in the system that can afford to do better to support the providers providing care can do so.
Thank you, Dr. Okeke, and I want to take a moment to thank all of the panelists. I want to just kind of call out some common themes we heard across all the speakers today, and that is, the community and clinic both have to be engaged, both have to make the right thing easy to do, and remove barriers. And secondly, leveraging a team in primary care, putting the in payment incentives up front, paying for prevention, really lifting up the value of prevention, taking barriers away from the patient. Valerie had barriers that she needed removed in order for her to get into care and get into consistent care. And then I think the IT, again, IT should not be an added burden. It should be facilitating, making the right thing easy to do. So with that, I want to again just thank everybody. And we got really good engagement in the Q&A. I think we know that this is not a problem about motivation. We've got the motivated clinicians. We've got motivated patients. What we've got to get them is systems and payment that are aligned to make the right thing easy to do. Thank you all.
Thank you.